Hey everyone, how's it going? Let me know if you can hear me. I'm having some issues with my camera today, so no video of me, which is probably okay by most of you, I imagine. I don't know who'd want to see me anyway, but let me know if you can hear me. All right, perfect. Yeah, sorry about the camera issues. It's, I think something with the software, but I'm gonna work on that for next week or final week. Yo, Dallas and Abby. We'll start here in just a minute or two. Of course, if you have any questions, feel free to post them up in the chat or on the sticky board. All right, well, it's 8 o'clock. Let's go ahead and get started here. If you have any issues, let me know hearing me. Like I mentioned, I have some camera problems, so you won't see me today, but that's okay. We can still get you some good info here. Someone had a question about the prescription assignment. If you want to use the inpatient one from last time, that's fine. Otherwise, you can go and use either prescription like blank page. That's fine by me for the last one here, since it's due on Friday. So some of you've already turned it in, so either way is fine. So let's get started with our talk on diabetes today. This is kind of the other part of endocrine that we'll talk about here. So glucose really important in terms of helping out with like energy utilization in the body. It's a precursor for a whole lot of different substances, lipids, amino acids, etc. Your brain can't really operate without the use of glucose, whereas your muscles and other organs can utilize other things for energy production. The brain really needs glucose. So let's talk about diabetes in itself, which is going to be this sort of metabolic syndrome. We're going to have issues where we have elevated glucose, right? This is going to be a problem over the long term because we can see issues in terms of like cardiovascular disease. You can see issues with the kidneys, neuropathies, all kinds of problems here. Someone had a question here. It said, on the ARCS assignment, do I have to put IV over a certain amount of minutes, or is that something more of a pharmacist or someone takes care of? If you want to give it something over a certain time period, then you have to put that. So, if it's specific in terms of how quickly to give something, then that is on you. You decide how quickly to give something. So, hopefully that makes sense. If not, let me know and I can clarify that. Anyway, I'm not going to get real heavy into the diagnosis of diabetes, but certainly you think about the three sort of cardinal symptoms, the polyuria, polydipsia, and weight loss there. Certainly you'll see things like elevated fasting glucose, you'll see things like A1C being elevated, which is, of course, is that sort of 3-month sort of window of seeing what their average glucose is like. And so these are kind of the things you'll see in terms of lab results there. In terms of the different types of diabetes you're going to get into, we'll mainly talk about type 1 and type 2. Type 1 obviously is where they don't produce their own insulin. This is usually a result of having an autoimmune response to the pancreas, where people will have basically destruction of the beta cells, thus they cannot release their own insulin. Type 2 is more so going to be an issue of insulin resistance. So, usually due to the metabolic sort of issues they develop over the course of years, they will develop resistance to insulin and have a tougher time maintaining normal glucose levels, because it's just their cells don't respond to it quite as well because they've had such high glucose levels and insulin levels over the course of years. So we'll look at some ways we can deal with that. With type 1, they're going to require insulin. Type 2, only about a third of those people may end up on insulin at some point. So we'll talk about different ways we can manage that. Certainly gestational diabetes is something you can run into as well with pregnancies. And then, prior to actual diagnosis of diabetes, you may have people with impaired fasting glucose. So usually they'll be sitting in that 110 to 125 range there. Patients with type 1 diabetes normally have issues in terms of like renal failure if they're not managed well over the course of years. With type 2 diabetes, they're going to have more macrovascular complications, things like heart disease. They'll be their ultimate demise, unfortunately. And then with in terms of risk factors, there's not really anything we can point to in terms of like type 1. But with type 2, certainly things like ethnicity, obesity, and lifestyle are going to be the big things we're thinking about in terms of things that are going to aggravate that or make that a bigger risk for those patients there. So getting to the pancreas, this is the most important organ we're going to talk about today. Certainly the alpha cells are going to be important here because of glucagon being the thing that is released from there, and this is going to be utilized for gluconeogenesis and glycogenolysis, and this is going to be important in the liver. So if you're in a state where you need to elevate blood glucose, glucagon is going to be really useful for that in terms of helping the liver convert its stored glycogen into sugar, right? And they can release that into the bloodstream. The beta cells are going to be really important as well because that's where we get our insulin from. So we're going to get into that more so, talking about things like proinsulin, C-peptide, etc. The D and the F cells we're not going to talk about so much, but this is important for pancreatic function and things like that. So looking at a typical patient with normal functioning pancreas versus someone who has type 2 diabetes, we're going to see that the alpha cells are going to be overactive. They're going to be releasing too much glucagon, even if you have normal or high glucose levels, which normally glucagon should be suppressed if you have high glucose levels. And their beta cells are going to be having this sort of progressive overuse and eventual destruction where they're going to be not able to release as much insulin in the long term, as we'll see. And I'll show you some graphs of what that looks like here in just a little bit. And again, you have a lot of excess sort of beta cell function, and by the point you get to someone who has actual diagnosis of diabetes, like they have to have pretty significant destruction and reduction in terms of function of those beta cells. So by the time you actually get someone with a diagnosis, they've already had some pretty significant damage already being done here, unfortunately. So with type 1, though, this is going to be something to where it's most often going to be an autoimmune issue, to where they'll have antibodies that will target those beta cells and cause destruction of that. You may have some non-immune cases, maybe about 10% or so, but for most of those people, it's going to be autoimmune. And sometimes you'll see this as well, where they'll have sort of multiple autoimmune conditions at the same time. So you may have a patient with type 1 diabetes on top of Crohn's disease, on top of some other stuff like juvenile idiopathic rheumatoid arthritis or something like that. So you can have kind of multiple issues kind of going on at the same time, unfortunately. But let's talk about insulin first. We'll kind of target this and we'll look at type 1 diabetes first because insulin is kind of the mainstay of therapy for them, and then we'll get into type 2 diabetes where we're going to see more varied sort of medications here. This is proinsulin. This is what your body would be releasing or producing naturally, and you'll see here that it is comprised of the insulin molecule, which is these two white sort of peptides here, and then I'll move this up a little bit. These two white peptides here, and then you're going to see that the blue portion here, blue purplish portion, is going to be called C-peptide. This is inactive normally, but this is all part of the pro-insulin molecule. And then when it turns into insulin, it'll cleave off the C-peptide and just be these two protein chains connected by these disulfide bridges here. So this is the actual insulin portion. The bluish, purplish portion here is going to be the C-peptide. C-peptide doesn't really have any function, but sometimes we can measure that in terms of telling us how much insulin the patient themselves is releasing, or if they're not releasing a whole lot there. And in terms of the kinetics of insulin, we're going to see that the liver will metabolize most of the insulin you have there, but the kidney is going to be responsible for excreting a decent chunk of that. And it has a relatively short half-life, and we're going to talk a lot about half-lives of different types of insulins here. But this is something important because you can see that the kidneys, if you have like kidney injury, if you have like an acute kidney injury, you can actually find patients developing hypoglycemia because they can't process that insulin as well. They can't excrete it, and thus they may actually have higher insulin levels than normal and may develop hypoglycemia. So it's something you can see if you have organ dysfunction, which is kind of interesting. And normally what insulin will do once it's released is it will go to different tissues, the skeletal muscle, the liver, it'll go to the adipose tissue. Those are kind of the three main targets there. And it will interact with these tyrosine kinase receptors where it's going to get internalized. And then eventually it will lead to glucose receptors being transported up to the cell surface. And we'll see that will help out glucose intake. Let's talk about insulin gets released in the first place. Going to the beta cells of the pancreas here, we're going to see that glucose will be uptaken through, or be taken up through these glucose transporters. You'll see the glucose transporters being called GLUT. There's different GLUT transporters here. GLUT2 specifically is on the pancreas. I'm not going to ask you specific questions on which GLUT transporters are where. I don't really care that you know that. Just know that there are glucose transporters. And so anyway, so glucose is going to come in through these GLUT2 transporters on the beta cells, and that glucose gets turned into ATP just like it would through normal energy production elsewhere in the body. That increase in ATP is going to close off these potassium channels, and that will then cause depolarization of the cell. That increase in electric positivity there will then cause these calcium channels to open up. Calcium channels then come into the cell, and that will cause these vesicles full of insulin to be, they'll fuse with the cell membrane and then release the insulin out into the bloodstream, basically. So I'll show you what this looks like here. Glucose coming in through the glucose transporter. So it's converted to ATP. This is going to close off these potassium-gated channels here. And that causes depolarization. Thus, calcium comes in because these are voltage-gated. And that causes insulin vesicles to fuse with the cell membrane that releases insulin. We'll see some drugs actually can do this directly, so we'll get into that a little bit later when we talk about type 2 diabetes here in just a little bit. So we're going to see that insulin itself is really responsible for causing your different cells to cause increased uptake of glucose and along with some other things, because insulin itself is an anabolic steroid. It's going to cause development of things like muscle tissue and fat tissue and things like that. And again, that glucose can be utilized for energy, but if it's you're in a excessive glucose state, you're going to then store that maybe as fat or something like that over time in order for storage for later uses potentially, right? So the actions of insulin are actually quite complicated in terms of its different effects in terms of growth and cell growth and things like that. But basically what I want you to kind of take away from this is that insulin will interact with these tyrosine kinase receptors that will then lead to a whole host of different changes. But the main one we're focused on is this translocation of the glucose transporters up to the cell membrane. Once that occurs, then you're going to be taking up more glucose out of the bloodstream and taken into the cell for energy production or energy storage, right? And when it's stored as energy, it may be glycogen. It can be eventually converted to fats to be stored in the adipose tissue, things like that. So normally what you're going to see is that the effects of insulin are dependent on the tissue that you're kind of talking about. So with the liver, we're going to see this is going to stimulate storage of glucose as glycogen. It's also going to have some effects in terms of converting things like sugars into fatty acids, VLDL. We talked about cholesterol previously. and should inhibit things like glycogenolysis and gluconeogenesis, right? Because if you're in a high glucose state, you're going to be releasing more insulin. Obviously, your liver doesn't need to produce glucose because you're in a high glucose state, right? So it's going to be more of a storage sort of case there. With the skeletal muscle, you're going to see this will also help to stimulate storage of glucose as glycogen. You'll also see this helps with storage of things like amino acids as protein. So you'll see this a lot with sometimes you'll see this with bodybuilders and weightlifters to where they'll utilize insulin, obviously not with a prescription. They may be utilizing insulin to help build muscle because it also helps with the uptake of things like amino acids. And will inhibit the degradation of muscle into amino acids as well because you obviously have enough glucose for energy utilization. In the adipose tissue, you're going to see this will help to store fatty acids as triglycerides and will then also inhibit the opposite function there. And so again, it's not necessarily fats that make you fat, but it is carbohydrates typically because of the effects of insulin and helping to store that as triglycerides and whatnot. So normally what you'll see is a pretty typical response with insulin is that you'll have some degree of basal release of insulin throughout the day, and this deals with the normal basal glucose levels in the body, right? You never want your glucose to get to zero because then your brain's not going to be functioning and then you'll be dead, right? So what you'll see is that you'll have a basal amount of glucose in the body, normally, say in the 70 to 80s range, depending on what's going on there. And then you'll have typical spikes in your glucose, which is related to meal times. Well, again, you're going to have insulin levels that are sort of being released at sort of basal amounts throughout the day. And then you'll have spikes in your insulin release due to meal times, right? So what we're going to see is when we're giving patients who have diabetes insulin, we're going to try to mimic this as best we can. And so we can either do this we'll have several different means of doing this, and it may be related to the types of insulin we're using, or it may be related to the dosage form that we're using, as we'll see here in just a little bit. There are over 17 formulations of insulin that are available, and so we're going to look at the different types, and it's your responsibility to know sort of the different ways that these are working in terms of how long they work for, how quickly they work, things like that. So we'll get into that in here in just a few minutes. We can do various things to the insulin itself. We can try to modify it. We can change out the amino acids. We can change the formulation, and that will help to change how it's going to be working, whether it affects the duration of action, how quickly it works, the onset, things like that. So we'll get into that in here in just a few moments. But just some examples include adding zinc to the formulation, which may affect how long it's going to work for. We can add protamine, different things like that. And so I'll show you some examples here in just a moment. So again, this is proinsulin here, which you see the C-peptide here, and then the actual two amino acid chains, which are going to be connected by these two disulfide bridges, and this is the actual insulin itself. Now, back in the day, we didn't really have an ability to, have easy access to insulin, so we had to do things like use animal forms of insulin because there's enough cross-reactivity to where it would work for people. So we used to use things like bovine insulin, which came from cows. So you can see there's just a one amino acid change here. And then we also use porcine insulin as well, which is coming from pork sources, pigs. Nowadays, we don't have to use that so much anymore. We have synthetic ways of producing insulin, but you can get some ideas in terms of how we can change even just a few amino acids. So, for instance, with insulin Lispro, we're changing a proline and a lysine and switching it to a lysine and a proline, and that completely changes the characteristics of how quickly it works or how long it works for. I'm not going to have you memorize the amino acids here by any means, but just to give you some examples of how small changes can make big differences in terms of how it's going to work. So we'll get into that here in just a few moments. So as I mentioned, we used to use animal sources. We don't use them as much anymore because of the fact that they're really antigenic, meaning they can cause allergic reactions. You can still get pork insulin, but it's via very special use cases. I've never actually seen it used in person. You can get it via special order. Nowadays, though, as I mentioned, a lot of these are made recombinantly, meaning we can take things like E. coli or yeast and actually modify those molecules or those organisms to produce the insulin for us, right? We can change our genome to do that. So as an example here, you get E. coli being used for the Lilly products. whereas baker's yeast can be used for the Novo Nordisk products here. So you'll see the for instance, like Novolin or Humulin being kind of like the two big manufacturers here in just a few moments, as we'll see. So how we're going to break up the different insulins here include the ultra short acting or short acting, which is regular insulin, intermediate long acting, and ultra long acting. There's even an inhaled form, which is kind of interesting because traditionally these are proteins, and so they can't really be administered orally because the GI tract would just break them down into their constituent amino acids for it'd be not effective anymore. But we do have some examples of inhaled formulations, which may be used. It can be absorbed from the lung tissue, but that is not as frequently used as we'll see here in just a little bit. But looking at the various forms, you're going to see that the shorter acting varieties have a much faster time to their peak onset, meaning that they can be useful for dealing with acute changes in glucose, meaning things like mealtime. So we'll see here that our ultra short acting ones can be useful for around meals or for quick correction, whereas our long acting forms, things like insulin detamere or glargine, they're going to be more useful for helping to replace the basal amount of insulin that a patient may be missing or is not as effective in the case of type 2 diabetes. So I'll give you some more examples here. But again, this is why it's so important to know the differences between the various types of insulin, because you don't want to accidentally give someone the short-acting type when they really need the long-acting, and vice versa. That can lead to a lot of issues there, as we're going to see here in just a little bit. Now, as I mentioned, sub-Q injections is far and away the most common form of insulin administration you're going to see there. Typically, this is either done by drawing it out of a glass vial and injecting that via a high gauge short needle. Typically, abdominal administration is done most frequently because this is what patients can kind of easily give to themselves. Especially type 1 diabetic patients here. Otherwise, you may see things like portable pen injectors, where basically they can dial in the dose, how much they're going to give. That's kind of like a twisty top. They can dial in how much they want to give, and then using a needle that will attach to that, they can then inject themselves. For some patients, you're going to see they can actually even use sub-Q continuous pumps, which are kind of interesting. And this is a picture you can see here of this black and white picture of one of the first insulin pumps that they ever used, and you can kind of see how cumbersome and sort of conspicuous that is. Obviously, things have gotten a lot better, and nowadays you can see some of the more modern sort of insulin pumps here. They are smaller than the size of I know most of you are too young to know what pagers are. If you've ever seen a pager, it is even smaller than that, which is pretty cool. And basically, there's a reservoir that contains the insulin, and it will slowly infuse insulin to the patient. You can program in your boluses and things like that. Erica's asking, are insulin pumps just used for type 1 diabetes? Most commonly, you're going to see that for most type 2 diabetic patients, they're going to get away with just using the long-acting form of insulin. So we'll talk more about that in just a little bit. But for patients who require exogenous insulin for survival, meaning most of your type 1 diabetic patients, insulin pumps can help to provide that. So we'll look at some different ways we can use that here in just a little bit. Here's an example of the inhaled form. Again, not used too commonly, but you can see here the cartridge that contains the insulin, and they can kind of breathe through it, kind of like a tiny inhaler sort of formulation there. So, again, I don't care that you know necessarily what size or, form that the insulin comes in. I just kind of provide this rightmost column here, some examples of, how they might come either as a pen or as a vial, things like that. But I do expect you to know sort of the delineation for the different types of insulin and what category they fit into. So, for instance, you should know which ones are considered the rapid acting insulins, or the ones that have the shortest duration of action but the fastest onset. This includes your insulin Lispro, which is Humalog, insulin Aspart, which is Novolog, and then insulin Glulicine or Apidra. These three are your rapid acting insulins. These are really good for mealtime correction of glucose. So if I'm about to eat a meal and I have a bunch of glucose coming in, then these are the ones you're going to want to use. This or regular insulin. And when I say regular insulin, this just means the natural form of insulin that most patients produce in themselves. And again, the only difference here in the brand names is basically what organism was designed to produce that insulin in the first place, whether yeast or E. coli. Oftentimes you're going to see that insulin is not dosed in milligrams or micrograms. You're going to see it's dosed in units, which is why it's really important to spell that out. You're going to see that one of the most dangerous drugs you can work with on a routine basis may be insulin. It's very easy to kill someone with insulin if you're not careful. And so that's why it's important to get things like the dosing correct and things like the concentrations right. You may see most frequently insulin being used as the U100 form. This refers to the concentration, and U100 basically means it's 100 units per ml. We're going to see some cases where that can be changed and use more concentrated forms here in just a minute. But when I say regular insulin, that just means it's the natural form that you or I produce. So Humulin or Novolin R. So if you see the R, that means regular insulin there, okay? We also have some intermediate acting forms. So if you ever see like NPH insulin, Humulin N, Novolin N, these are more intermediate acting. This may be something you would do like maybe twice a day. These normally contain things like protamine in it to help the formulation last longer. They won't have as intense of a peak as a short or ultra short acting, but they will last, maybe 12 hours out of the day. And then you'll see the long acting insulins. These are typically done Q24 hours. So very long acting. This includes insulin glargine, insulin detamir, or insulin degludec, or Lantus, Levemir, and Tresiba, respectively. You can even have combination products where you contain both the short acting plus a more intermediate acting. I see these used less and less frequently nowadays. Most of the time I'll see patients utilize a long acting form plus an ultra short acting form together in order to help provide both basal coverage and then mealtime insulin requirements. And I'll show you some graphs of what that looks like here in just a little bit. Again, I don't care to know which combination products are available. I'm just kind of showing this to you to get an idea of what's available that's out there. But if I ask you on a test question, I say, which one of these is a long-acting insulin or which one of these is short-acting, you should be able to kind of pick that out based on the list there. Now, you can also see more concentrated forms of insulin, things like, U500, U200. You want to be really careful anytime you use these because if you miscalculate how many units you're giving, or if you're using the wrong type of insulin, you can really run into some problems. You can either give too much insulin, which can cause fatal hypoglycemia potentially, or you can give too little insulin, and that can lead to, kind of unchecked hyperglycemia there, which can be a problem. So again, familiarize yourself. Mainly this first slide or first chart here is the big one you want to focus on in terms of knowing which type of insulins fall into which category. So that's certainly good to know. Here's a table that kind of shows you the difference in terms of the onset of action of the insulins and both the duration of action, which I think are kind of the two most important points here in terms of how quickly they're going to come on or how slowly they might come on in terms of action, and then how long they're going to last for. So if I need something that's going to be able to last throughout the day and provide sort of basal coverage of insulin, then I might use a long-acting like detamir or glargine, versus if I need something to help cover a brief spike in glucose like mealtime, then I can use insulin aspart, lispro, glulisine, or the inhaled form if I need to, just as an example. So in terms of complications of using insulin, hypoglycemia is far and away the most common and the most problematic of the bunch. We'll talk about ways to treat hypoglycemia in just a little bit. But again, this is more common if you mess up and use the wrong concentration of insulin, you use something more concentrated than what you expect. And again, it may sound simple to give someone, like just give them the right dose of insulin. You won't worry about it. But again, human errors happen all the time. You'll be surprised by just how easy it is to accidentally harm someone with simple human errors. You can also run into issues to where patients can develop reactions to the insulin. This is sometimes related to their immune system developing antibodies against it. So you can actually develop insulin allergies. And again, you may think, okay, well, regular insulin is something that we produce ourselves, so how can you have an allergy against that? Sometimes it may be a reaction to something formulated in the product, so it could be like the protamine they're reacting to or something else. So that's something to consider there. Sometimes you can develop resistance to where it's not that your antibodies are causing anaphylaxis, right? But they can actually still neutralize the antibodies or neutralize the insulin through IgG antibodies. and that means that over time the insulin may become less effective because it's being neutralized essentially. The most common reaction you're going to see is mainly due to injection site reactions, and this is related to the fact that most insulin is usually stored in the fridge because it's a protein, and if it's stored at room temperature, it has a little bit of a difference in terms of the shelf life of it. Typically, if you're using a vial of insulin, it's only good for about 28 days at room temperature. In the fridge, it definitely has a longer shelf life there. But if you're injecting cold insulin, then that can cause this kind of vasodilation sort of reaction. So that's probably the most common thing you'll see, but it's not really a true allergic reaction you'll see there. But it can be kind of painful for the patient. We also recommend that they go ahead and rotate their sites, so that way they're not injecting in the same spot every single time, because they can develop this lipodystrophy that occurs there. And then the other most common side effect you're going to see here is weight gain, because by supplying insulin, you're going to cause storage of all that glucose in the muscles and in the fat, and that's going to cause your weight to go up. So we'll talk a lot about weight in terms of different effects of medications as we go forward. Julie's asking, do all the synthetic insulins have cross-reactivity if a patient develops an allergy to one, or can you just switch to a different one? That's depending on what specifically the body's having a reaction to. So, for instance, if it's a specific, amino acid change that they're responding to, then you could switch to a different insulin product and it won't be a problem, right? I find it pretty rare that we run into issues in terms of patients having allergies to insulin products. More often than not, it's either due to an animal product, which is why we don't use them much anymore, either bovine or porcine insulin. We don't use too often. Or the protamine is going to be a problem. So you'll see that with the NPH types of insulin there, which honestly I don't see a ton of use anymore. It's mostly just either the regular insulins we use on the ultra short acting or the long acting I see most commonly nowadays. So, good question. So who are we going to use insulin for? Typically, all of your newly diagnosed type 1 diabetic patients here. We may see it being used for gestational diabetes occasionally, especially if it's not being controlled by diet alone, or we may use it for type 2 diabetic patients who are not being controlled with oral medications, which the whole second half of this lecture is going to be focused on the oral meds we can use for type 2 diabetes. We can use it for diabetic ketoacidosis or DKA. We can use it for HHNS, which is a hyperglycemic hyperosmolar non-ketotic syndrome. This is something you're going to see more so in type 2 diabetic patients, or we can even use it in hyperkalemia, which is kind of interesting. You can use it to sort of shuttle potassium into the cells in order to kind of drop their patient's potassium level briefly. Or, say for instance, having hyperkalemia, their potassium's like 6 or something, you can try to drop that down briefly there. So, talking about type 1 diabetic patients specifically, again, these need to be tailored to the patient's lifestyle. The whole point is to try and make sure that we are letting the patient have as normal of a lifestyle as possible without having to worry about, taking time to inject themselves or check their blood glucose all the time. But they're going to have some degree of normal life interruption because of this. And so typically they're going to undergo what we call a basal bolus regimen. And a lot of this is going to be based off of their self-recorded blood glucose readings here. Basal bolus just means basal is going to be covering sort of the 24/7 amount of insulin that the body would normally be releasing otherwise, which is normally normally we're going to use the long-acting forms of insulin to cover this. I'll show you some graphs of what this looks like in a moment. And then bolus doses are being used to help cover mealtime corrections of glucose. So if I'm going to be eating something that contains carbohydrates, like a big, maybe like a donut or something, then I need to take into account how much glucose that's going to be, and I can dose my insulin according to that. So that'd be a bolus dose of insulin. And so you can either do that via multiple daily injections, or you could do this via something like a subcutaneous continuous pump. And so that's kind of the dosage forms I was showing you just a few minutes ago. And that you'll just use a short-acting form of insulin that can be infused kind of 24/7, and that will actually help cover both the basal and the bolus, as we'll see here in just a little bit. So I'll show you what that looks like on the graphs. Basically, what you're going to see is that the more often you're injecting a patient or they're injecting themselves with insulin, you're going to get tighter glycemic control, meaning they'll be closer to their, what you consider to be normal glucose levels here, but the complexity is going to be higher. They're going to take more time to check their glucose and give themselves shots and everything. If you're doing it less often, you're going to see more risk for things like hyperglycemia occurring there. But you'll have less chance of hypoglycemia. So it's kind of a balancing act in terms of making sure you're getting tight enough glucose control for these patients, but not so tight that it's kind of being restrictive on their lifestyle or in terms of causing hypoglycemia here. So a couple ways we can do this is to one, make sure that we are trying to match their carbohydrate intake with their insulin dosing that they're using, and along with their physical activity as well, because obviously if you're physically active, you're going to be utilizing glucose. And thus you may not need as much insulin. So for instance, if you have someone who's like, and typically think about type 1 diabetic patients as being relatively young, you may see that if they're participating in high school sports or something, they may need to adjust their insulin dose based off of them, going to track or wrestling or whatever the kind of physical activity they're doing there. But again, the goal is to try to be as unintrusive as possible here and try to make this as simple as we can. And typically the insulin we're going to be using is going to mimic what the pancreas would normally be doing. The pumps can help to do that, right? They can help to provide both a basal amount of insulin release kind of being infused throughout the day, kind of 24/7, and then provide boluses as needed. But unfortunately, the devices we have nowadays are not, smart enough to be able to respond to changes in blood glucose. We're kind of getting there as time goes on. But, it requires a patient to be able to figure out how much insulin they really need. And so what they're going to do is look at things like, meal patterns. They're going to look at kind of their carbohydrate intake and try to help to give insulin that's going to help to mimic what the pancreas would normally be doing there. Eric is saying, if the sugar becomes too low, would it be safe for them to drink juice or eat something with sugar or bring it back up? Or is there something given to correct that when they are home? I will show you how we correct hypoglycemia here in just a few moments. So bear with me, and I will talk just about how we treat that in just a moment. Typically, though, for those patients, you're going to see that once or twice daily dosing of insulin is typically not tight enough, and we're going to need more frequent than that for most of these patients here. So. As I mentioned, this is what normally your pancreas would be doing in response to glucose changes in the body, right? So again, you're going to be releasing some basal amount of insulin throughout the day, right? So your pancreas is always releasing some. Oh, you have to apologize, Erica. You had no idea this was coming up. But you'll see that you'll have these spikes of glucose here, and thus you're going to have spikes of insulin to go along with that. And so you can either have patients inject themselves to help mimic this, or they can have the pump actually be programmed to do this as well. We'll see some ways we can try to do that. So generally insulin doses should be dependent on the carb intake as long as the exercise that they're going to be doing there. And then the long-acting insulins are going to be used typically in the morning or in the evening. A lot of these are going to be done Q24, so kind of like one time daily, or they may be twice daily depending on the case there. And then we're going to use the rapid-acting insulin. And we can do this a few different ways. So we can use this as what we call a sliding scale. This means that they will change their insulin dose based off of their glucose levels. And so this means that if it's, if their glucose is between 120 and 130, they're going to give this many units. If it's between 130 and 140, they're going to do this many units. This is going to be dependent on the patient's own insulin sensitivity. So how much will 1 unit of insulin change their glucose? And this can be dependent on the patient. It can vary between one to another. And so they may have a sliding scale that they can use. In addition to that, they can also do carb counting, where basically if they know how many carbohydrates they're going to be intaking based off of, and this is where things like, MyFitnessPal and other, nutrition tracking apps can be super useful. They can basically figure out how many carbohydrates or how many grams of carbs they're going to be intaking, and then give insulin to help correct for that. So if they know they're taking in, say 20 grams of carbohydrates, they can give this many units to help correct for that. And again, that insulin sensitivity is going to be dependent on the patient. It can be a little bit different for every person there. So this is a good table or graph here to kind of show you the different types of insulin administration that we can use in order to help provide as good a coverage as we can for these patients. So this top graph here is what your glucose levels will sort of look like throughout the day. Notice you here again, you're going to have a basal amount of glucose. You'd never want your glucose to be 0 because you'd probably be dead or at least unconscious. And then you have these spikes here that are related to your mealtime intake, right? And what normal insulin levels would look like for a typical healthy patient is going to be, you'll see spikes of insulin that are closely related to that mealtime, right? Along with the basal amount of insulin that you're going to be releasing anyway. Okay. So what are some ways we can apply insulin in order to help sort of mimic this for your patients? Well, here's an example of a twice daily injection, so not too frequent of injections, where they would give basically kind of an injection of both regular and NPH insulin in the morning. So that would help, the regular would help cover the breakfast time insulin. Notice the kind of delay in the peak action as opposed to your pancreas releasing insulin. And then you'd see that the lunchtime, I should say, is going to be helped covered by the NPH insulin. Then at supper time, they'll then get another shot, which contains both regular and NPH insulin. That will help provide coverage for the dinner time. And then for overnight, you'll have the NPH insulin working there. So that's only twice daily injections. See, it's not as great because you're going to have areas where you're not getting really good coverage, or it's not going to be helping with the mealtime quite as well. Again, you're relying on the NPH to cover for the lunchtime. So you don't see this done too frequently. More often than not, what you're going to find is some sort of maybe 3 to 4 time daily injection where they're going to get a long acting in the morning time, maybe evening time, most often the morning. And then you'll see that they will then give a regular or ultra rapid acting insulin. Normally, you're going to see an ultra rapid acting insulin being given for the meal times. Normally, like 30 minutes beforehand or at mealtime. You can then give 3 injections per day for meals, and then you have the 1 injection for the ultra long acting in the morning time. So this would be a 4 injection sort of system here. And then that, again, more injections, less, and more issues for the patient because they're having to shoot themselves up more often. But you'll see that this also helps provide tighter coverage for their glucose levels. Now, the most the best way you could do this, if you had an insulin pump, for instance, would be if you just had a pump releasing regular or fast-acting insulin throughout the day, and then you could program in when to give insulin boluses. So you could do that at different meal times there. Basically, the patient would be able to control the pump and say, okay, I'm having this many carbs, I'm going to program in this many units. And so they can program in the basal amount they're going to be getting throughout the day, and then they'll program in the boluses when they need to. And again, this requires the patient to be pretty savvy in terms of controlling their diabetes. I see kids that are, 8, 9, 10 years old that know how to control their diabetes better than I probably could because they are so used to it. They can program their own pumps, no problem. And we'll do this in the hospital. Pretty commonly where the patients will be able to use their own insulin pumps in-house there. Hey, how's it going? But anyway, so let's, as I mentioned, the insulin pumps, they provide basically an artificial pancreas, which is, pretty handy for the patient there. But again, it requires them to be pretty savvy and have really good attention to detail, because if they are not careful, they can provide themselves too much insulin or too little insulin, and obviously it's going to be some issues in terms of hypoglycemia there. So it requires a lot of training. But as I mentioned, young patients, they can get really savvy with this stuff and can be really good about controlling their diabetes. But if it's someone who's going to be non-compliant, if it's going to be someone who is not able to work the pump very well, this is going to be a bad option for them. However, you can also see issues in terms of pumps malfunctioning. You can have them release either too much or too little insulin, and that can be a reason for hospital admission in some cases there. So again, it's not foolproof, but it is a really nice way if you have someone who is with it, who is compliant with their regimens, who has really good control of their diabetes, switch them over to a sub-Q pump, and that way they can just have this thing that's running 24/7. It's very, they don't have to inject themselves as often because there's a sub-Q pump or sub-Q catheter that is placed and is just kind of sitting there for a period of time, usually, several weeks to months. And so that's, very handy for the patients in terms of being sort of non-intrusive into their lifestyle, which is great. So kind of getting back to Erica's question, what do we do if the patient is hypoglycemic? So one, they need to know sort of what the signs and symptoms of hypoglycemia are. So, in some cases you may find patients are not really may not have good understanding of hypoglycemia. So you want to let them know kind of what the signs and symptoms to look for are. So things like mental status changes, sweating, tremulousness, things like that. But some patients may even have issues to where they become unaware of the hypoglycemia due to things like neuropathies. So we'll see some patients have issues in terms of that. Julie's saying, I thought patients normally weren't allowed to use their own insulin pumps while in the hospital. Am I correct in thinking that? Yeah, so that depends. The reason why they're in the hospital, so for instance, like we have a policy at our hospital to where if the patient's coming in for something else, like if they're coming in for, I don't know, say they got COVID or something, and they're on an insulin pump normally, as long as they can show competency that they can use their pump correctly, and normally this is like something like the pharmacy may do occasionally, then we can allow the patients to use their own insulin pumps. So just like they may use some of their own home medications, they can use insulin pumps there. But some cases, the providers may say, nope, just go ahead and we're going to discontinue that and utilize sub-Q insulin intermittently. It just depends on the provider there. But yeah, if you can keep them on their own home regimen and it's working well, I say don't break what's working for them patients. Don't try to fix what's not broken. Anyway, so with hypoglycemia, this is typically characterized as something less than blood glucose of 65 to 70. Now, oftentimes when patients are feeling hypoglycemic, they tend to overcorrect. They tend to say they tend to feel hypoglycemic, so they're going to say, okay, I need to get some glucose in, and they'll kind of overcorrect it, and then they develop hyperglycemia. Not great. So what they can do, as long as they're kind of awake and with it, and they're conscious, then we can do what we call the rule of 15. And so kind of going back to what Erica was saying in terms of utilizing juices or something, yes, you can. Basically, what we're going to recommend is 15 grams of simple carbohydrates. So this is like orange juice, milk, something like that. Or oftentimes they'll have glucose tablets that may be recommended. And they'll get 15 grams of carbohydrates in. They're going to wait 15 minutes and then check their blood glucose. And if it's still less than 70, then they can repeat that process until they're above 70. Okay. That works well for patients who are still awake and conscious and all that. However, you're going to see with really severe hypoglycemia, they may lose consciousness, or they may be to a point where they're not really safe to take oral medications or oral intake. So what can we do for those patients? Well, basically, there's two things we can do. One is to give intramuscular glucagon. This is kind of similar to like a patient with a peanut allergy carrying an EpiPen with them. They can carry glucagon for these patients here. And so basically this will directly stimulate the liver to produce new glucose through glycogenolysis and gluconeogenesis. And so this is again, a protein, so it has to be injected. And you'll see here that it actually comes as a freeze-dried powder. So it is something that has to be reconstituted. So this is not something the patient's going to give themselves, because if they need it, they're probably going to be unconscious. So this would be something like, a parent or another, healthcare provider would basically be able to use the diluent that's in here, can reconstitute the drug. And then again, there's instructions here that kind of shows you what to do. And then they can then draw out the medication and inject this into the muscle. Again, this is not great for patients who have like kind of long-standing hypoglycemia, because their liver might be out of glycogen to convert over. So that may not always be effective, but it does work for some patients, especially in the out-of-hospital sort of setting there. It does cause quite a bit of nausea, vomiting, and again, it's not great for a patient who might be unconscious, because they could then vomit and aspirate. But it's just something you're gonna might want to put them in the recovery position or something. But it's a risk that we're aware of. Interestingly enough, sometimes we can actually use this to help patients who have foreign bodies in the esophagus, because it helps to lower or loosen the lower esophageal sphincter. So occasionally, if we have patients who have swallowed a quarter or something and stuck in the esophagus, we can use that to help pass it. But sometimes works, sometimes not. If glucagon's not going to work, or if it is not available, then we can give IV dextrose, right? Because that's what they're missing, so we can supply that. And this has various concentrations. You may see like D10, D25, D50. Obviously, the bigger the number, the more concentrated it is. And typically, we'll give between half to 1 gram per kilogram. Usually, we'll max out about 25 grams of carbohydrates that we're giving at one time there. Again, the dose specific, I'm not going to ask you on the test, but just for your knowledge. The higher concentrations are going to be rougher on the veins, and so this can cause things like thrombophlebitis. So typically for like young children, for infants, we're going to use the less concentrated forms, like D10 for infants, D25 for like children, and then like D50 can be used for like adults, or if they're like coding or something like that. That's where we can utilize the really concentrated forms there. Is that intravenous insulin is preferred in hospitalized patients, especially with severe hyperglycemia or rating scale. Yeah. So you'll see that with patients being admitted, if they have like diabetic ketoacidosis or HHS, we will utilize IV insulin there. But still, sometimes even for sliding scales, for like a type 2 diabetic patient, you'll see sub-Q still being used, especially if they don't have like an established IV in place there. But yeah, so different options you have for sure. So Detamere causes carcinogenic. Not that I'm aware of. I don't know that the cancer risk is too high with that for sure. Yeah, I'm not aware of anything in particular. So, let's see here. So type 2 diabetes. So that's kind of our kind of going over all the insulin types there. Again, be aware of what if I ask you on a test question, which one of these is like a fast acting, or which one of these would be this is a troll, you think? It could be a troll, perhaps. They seem like they have some knowledge. I don't know, maybe it's just a passerby, perhaps. Who knows? And we'll see if they're more disruptive. I can always kick them out if need be, right? So anyway, so if I ask you on a test question in terms of like which one of these would be considered like a fast acting or long acting, or which one are good for good for instance mealtime coverage, or if they're good for kind of providing basal coverage, that's sort of the things I'd want you to know for like a test question, right? And then know how to treat hypoglycemia, things like that. Yeah, I don't think they're in class yet. I was like, I don't recognize the name, but that's okay. Passerbys, I don't mind as long as they're not being disruptive. But we'll see if they have any other comments to make there. But anyway, so let's talk about type 2 diabetes here. Basically, for type 2 diabetes, lifestyle changes are going to be like kind of the most common thing you're going to recommend. Things like changing their diet, changing their exercise activity, things like that are going to be really important for them. We're going to then see that we're going to focus on oral monotherapy. So if we can go ahead and use things like one single oral drug, that's going to be really helpful. And then we're going to see that we'll try things like combo therapy, typically with oral drugs only. And then we may need combo therapy with, some sub-Q drugs. Insulin is going to be ultimately what these patients might end up on if we're not able to control them with oral monotherapy or some other medication types here. So, and at the end of this, I'll show you a table that will kind of show you all the different combos you can use and sort of what the risk and the downsides are for a lot of these. So anyway, so kind of going through the different classes of drugs here. The first one we have is that drugs that can stimulate the pancreas to release its own insulin. This is going to include our sulfonylureas and then meglitinides. We're going to have drugs that sensitize the body to insulin, and they kind of help with hepatic glucose production or help to limit it. We'll include our thiazolidinediones. That's kind of a mouthful, so you can say TZD, or your biguanides, which is going to include our metformin, which I'm sure most people have heard of. We can have drugs that slow down the absorption of starches, so this includes your alpha-glucosidase inhibitors. We'll talk about how they work in a little bit. We'll have our incretin drugs, either helping out with preventing the breakdown of incretins that we produce or helping to replace them. We'll see. And then we'll have drugs that actually prevent the reabsorption of glucose from the renal tubules. And so this will be SLGT2 inhibitors. So we'll get into all these drugs and more specifics here in just a few moments. So the first group we'll look at are going to be the sulfonylureas. These are considered to be your oral hypoglycemics because they help the pancreas to stimulate its own insulin release. We have two generations here. Most of the time you're going to see the second generation being used because they typically are more potent and they're less likely to cause issues in terms of side effects. So for the first gen, you'll see things like acetohexamide, chlorpropamide. Chlorpropamide you still see used occasionally. You'll have talazomide, tolbutamide. And then more commonly, you're going to see in the second gen glimepiride, glipizide, and then glyburide. Again, a lot of these will come in like controlled release formulations or XL formulations to help kind of provide 24-hour coverage there. So what do these drugs do? Basically, they're going to help to block those potassium channels on the beta cells of the pancreas, kind of similar to how you would normally see glucose coming into the cell that converts to ATP to block this channel here, or to cause the closing of the channel. You're going to see that the sulfonylureas will do this directly. So by closing this channel here, you're going to have a lot more positive charges inside the cell that will cause depolarization, and then you'll have these calcium channels open up. Calcium flows in, and then there you go. You're going to see release of insulin from the pancreas. So independent of glucose levels, you're going to see your sulfonylureas are going to cause insulin release. So as you might imagine, you're going to see some pretty consistent side effects from this, meaning you're going to see things like hypoglycemia potentially, meaning you're going to see things like weight gain related to release of that insulin there. So other things you can also see as well is it can help to suppress the liver from producing more glucose and gluconeogenesis. It can help out with things like insulin receptor sensitivity and having a higher number of receptors, and it can help to suppress glucagon levels. You're going to see glucagon levels here in a little bit are going to be a problem for these type 2 diabetic patients here. Most of these get metabolized in the liver and then excreted into the urine. You may run into issues if you have either renal or hepatic insufficiencies. You may see prolonged hypoglycemia, which can be a bit of a challenge for these patients here. We also don't use these too often in pregnancy. There's some concern that it may deplete things like insulin from the fetal pancreas. So most often you're going to see that these are not like kind of first line drugs used in pregnancy, but it could be used occasionally. So with glimepiride, here again, you're going to see more insulin sensitivity. You're going to see that overall, if you're going to use this in addition to insulin for type 2 diabetic patients, you're going to see that the insulin dose they require is lowered because they're producing more insulin, right? You get more rapid glucose control, but again, you have to worry about the hypoglycemia. It's kind of the double-edged sword you're going to see with that. Again, this is going to be seen with the majority of these. Some of these may come in extended release formulations, and that helps to not require multiple daily dosing. And again, for a lot of these type 2 diabetic patients here, you're going to see that not only do they have diabetes, but they have hypertension and kidney disease and maybe COPD and other things that they're going to be taking medications for. So it's important to make sure that you're keeping the regimen as simple as possible. So we can keep everything once daily. That's going to be helpful to them from that standpoint. So in terms of adverse effects, again, pretty consistent because they're causing increased release of insulin. You're going to see hypoglycemia. You're going to see weight gain associated with this. And again, a lot of type 2 diabetic patients typically have obesity as another concomitant issue they're dealing with. So you may not want to give something that's going to cause increase in weight gain, but again, you got to manage your glucose as well. So it can be kind of a tough tightrope to walk there. Other issues that are rare include some things like leukopenia, thrombocytopenia. This is very, very rare. And you may see things like resistance over time. And this is due to the fact that with type 2 diabetic patients, they're just wearing out their pancreas as time goes on. So because you're stimulating it even further, they can help to expedite that sort of wear and tear on those beta cells there. So again, you may see it's really effective up front, but then it kind of loses efficacy over time, which can be a challenge. Things you would not want to use this for include things like diabetic ketoacidosis or type 1 diabetes. This makes sense because you're going to see that, excuse me, one sec. You're going to see that type 1 diabetes and DK, like those patients can't produce their own insulin anyway, so you wouldn't want to administer sulfonylureas for that because they're just not going to be effective. Again, it's a relative contraindication for pregnancy or breastfeeding. I'd probably avoid it if at all possible, but you'll still see it used occasionally. And then in terms of interactions, anything that can also increase insulin release or insulin itself that can cause hypoglycemia, this is going to worsen that. And then anything that causes hyperglycemia, things like corticosteroids, for instance, can lead to the drugs being less effective. So it's more so a pharmacodynamic sort of interaction you'll see with that. Anyway, so that's the sulfonylureas on the sort of in the same family, maybe not the same category, but maybe cousins to the sulfonylureas. We have the meglitinides. These are not used too frequently, but still good to when you see them to be able to recognize what they're being used for. This includes repaglinide and nateglinide, and they do basically the same thing as the sulfonylureas, but the only difference is that they only respond when you have an elevated blood glucose level, meaning they really only work during meal times. So you have to either take them with meals or maybe 30 minutes before meals, and you're going to see that these will help to release insulin in response to the elevated blood glucose due to you taking in carbohydrates through your food. Because of that, they're going to be given more frequently, so usually at mealtime, so you may be taking it 3-4 times daily. It's really important as well that they are going to skip a meal, then to skip a dose as well, because the drug's just not going to be effective for those patients there. So that's kind of the difference. So with sulfonylureas, they work irrespective of your plasma glucose level. With the meglitinides, they're only going to work when you have elevated glucose levels as a result of mealtime glucose intake. Okay, so that's kind of the big difference between those. These have to be taken with meals. Sulfonylureas can be taken kind of whenever. Again, similar as adverse effect profile with sulfonylureas. Nothing really big to note here. It's just that things like hypoglycemia is going to be less common with the meglitinides, mainly because if they're going to be intaking glucose, then that's going to help to blunt that hypoglycemic effect anyway. So, yeah. So overall, you can see it less effective, less commonly used, but you may see it occasionally. A really big class you're going to see used probably most frequently is in terms of first line therapy are going to be our biguanides. These are going to be basically just metformin. It's basically a class of one. There's been other ones like buformin or fenformin, but in the US we really only use metformin here. And so you may also see this used in a lot of combo products. Again, this is done to help out with compliance. So for instance, if you see like metformin and glyburide, you have a sulfonylurea plus biguanide. And again, this is a really good backbone to a lot of regimens because this helps really everything else work that much better. And we call metformin an insulin sensitizer because it helps, again, your body to utilize insulin more effectively because it helps out by dropping things like hepatic glucose production. You'll see increased peripheral glucose uptake and utilization, meaning you get better insulin sensitivity, which again, a lot of type 2 diabetic patients are very insulin resistant, as you'll see as time goes on. You're going to get less glucose absorption from the GI tract, and you have very limited hypoglycemia. This is why we start with this first, because it helps out all these different things. Again, helps their insulin to work better, and is very unlikely to cause hypoglycemia, as opposed to like your sulfonylurea. So this is why most people start out with metformin. So now we're going to see here that metformin itself is not metabolized in the liver, but we're going to see that if they have hepatic disease, you can actually find contraindications to metformin as a result of this buildup of lactic acid that can actually occur here. So we'll talk about the lactic acidosis here in a moment. Most metformin is going to be excreted unchanged in the kidneys, but if they have renal impairment, this is going to be a big contraindication to use here. Not because we have a buildup of metformin necessarily, but because it can cause a really severe lactic acidosis. So what you're going to see is if a patient have reduced creatinine clearance, typically if it's like less than 30 mLs per minute, then metformin is not going to be recommended for those patients because they can have that life-threatening lactic acidosis, as I mentioned. I've seen this a few times where I've seen patients actually die from this, to where they were typically elderly, like 80s, 90s years old. They have a decrease in their kidney function. They're on metformin, so they can't clear it very well, and then develop this like really severe metabolic acidosis. That's kind of something you want to be really cautious with in those patients there. The benefit you're going to see with metformin as well, in addition to helping the insulin that they're releasing work more effectively, is the fact that it also does not cause weight gain. And if anything, causes a little bit of weight loss. So that can be actually really good for patients because many type 2 diabetic patients have, are overweight or obese, right? The downside for metformin, in addition to the lactic acidosis, which is again seen more in that renal impairment, is going to be the GI side effects. It's going to be pretty rough on the stomach, causing a lot of diarrhea, heartburn, constipation. This can be mitigated by using long-acting formulation. So if you see metformin XR or XL formulation, that can help to limit that to some degree, or using a lower dose. But again, you'll just kind of see how the patient can tolerate it. You can also see some issues with anemia by having reduced B12 absorption, but that's pretty rare for the most part. I don't see too many patients develop issues with that necessarily. So, as I mentioned, the contraindications are going to be mainly renal disease. If they have a creatinine clearance less than 30, do not give them metformin. Contraindicated from that. If they have an existing hepatic disease, metabolic acidosis, or anything like that, and then they should probably be pretty cautious in using that. And then you'll see this as well that we'll typically stop it before surgery or before they get something like contrast, for like a CT or something like that. The reason why we do that is because during surgery you can have cases of acidosis developing anyway, so we want to go ahead and stop that. And if they're in-house anyway, in the hospital, you could switch them over to insulin regardless, right? So you could always give insulin to help kind of control their glucose during that 48-hour period regardless there. So again, you stop it around surgery, 48 hours, and then you can put them back on it, no problem. All right, and again, I'll show you a table that kind of shows the different, kind of the algorithm for how we're going to choose our meds here in a little bit. But typically, metformin is going to be one of the first drugs that most people end up on. Next, we have our TZDs, or thiazolidinediones. Again, it's kind of a big big mouthful there, so TCD is fine. We have 2 drugs in this category, including pioglitazone and then rosiglitazone. These are going to work by being an agonist for this peroxisome proliferator activated receptor gamma, or PPAR gamma. Again, a lot of big words here. This helps out with things like regulating transcription and insulin of the insulin responsive gene. So basically, this is going to help out a lot with insulin sensitivity. These were used a lot more frequently, but they've had a bit of some challenges to their use here. So I'm seeing these used less and less frequently, but you'll still see them occasionally, which is why you need to be aware of them. But again, this is going to help out with things like glucose and lipid metabolism. Again, they're going to be sensitizers, similar to how metformin does that as well. So you're going to see increase in peripheral glucose uptake, utilization. You're going to see more insulin sensitivity, which again, I mentioned type 2 diabetic patients are typically insulin resistant. And you should see some less hepatic glucose production as well. Because they're working more so on gene transcription, they're going to take a while to work. It's like 6 to 12 weeks before you really see effects, as opposed to something like insulin, which works, almost immediately, especially if you're using a short-acting formulation there. So in terms of adverse effects, some things you might want to be careful of are going to be in CHF patients, because this can cause things like elevated or expanded blood volume, edema. This may cause, exacerbation of CHF in some patients there. You can see things like limited weight gain. It's fairly limited, especially as compared to something like sulfonylurea. See some changes in your lipids there. And the LFTs are really the big thing you're going to be monitoring for. So if they, do a baseline, do a follow-up, and if they start to see the ALT start to trend up, then you'll probably want to discontinue it there. So those are the big things to really worry about. CHF, liver failure, things like that, and then certainly monitor liver function over time as well. Next up, we have the alpha glucosidase inhibitors. These are going to be basically 2 drugs here, acarbose and miglatol. These are used uncommonly, but again, you may still see them occasionally, so it's good to know about them. And these are basically going to block the actions of alpha amylase and alpha glucosidase. These are enzymes, typically in the intestinal brush border, that will aid the body in metabolizing longer chain carbohydrates into their smaller constituents that aids absorption, right? If you block those enzymes, those carbohydrates can't be broken down unless they're just going to sit there in the GI tract and not be absorbed, okay? Thus, you have less glucose absorption. Thus, you're going to have lower glucose levels overall, right? Sounds like it's pretty good option there. May even lead to some weight loss, you might imagine, right? We're going to see this is beneficial because, for one, they really help to limit, they really have very limited systemic exposure. Most of them don't get absorbed to a large degree, and so that may be useful for patients who want to have, limited exposure of drugs to maybe like a fetus, for example, there. These have to be taken with meals, because again, that's when they're going to be able to inhibit those enzymes and prevent that glucose from being absorbed there. And again, you're going to see this can be used either by themselves, probably not often by themselves, or in addition to other things, plus insulin perhaps. The problem with these drugs, and why you're not going to see them used too often, is the GI side effects. So what happens to all of that glucose that's sitting there in the GI tract that's not being absorbed? Well, it's going to get metabolized by something. It's probably going to be your colonic bacteria, and that bacteria is going to turn all of those carbohydrates into CO2, right? So you're going to see a lot of flatulence associated with this. You're going to get a lot of things like abdominal cramping and pain, diarrhea. So because of that, because of the negative GI side effects here, you're going to see that patients are not going to be too compliant with this, and which is why it's not used too frequently. You also want to be careful for anyone who has things like inflammatory bowel disease or any kind of GI obstruction, ulcerations, anything like that, because again, that increase in the gas being formed there can cause injury to the GI tract. So if they have like Crohn's disease, ulcerative colitis, I would probably just avoid these drugs altogether for those patients. So the next set of drugs I want to talk about have to do with incretins. And incretins are a set of hormones in the body. The main one we're going to talk about here is called GLP-1, or glucagon-like peptide 1. And GLP-1 actually has several functions in the body here we're going to see, including affecting the beta cells. This actually helps to enhance glucose-dependent insulin secretion. So if they have glucose coming in through your food, for instance, you're going to be seeing more insulin being released there. We're going to see that in the brain, it helps promote satiety. So when you're getting full, you'll have GLP-1 being released that says, okay, I don't need to eat anymore. You're going to see this helps to suppress glucagon levels and will help to suppress liver production of, or hepatic production of glucose there. and it also helps out with the effects of regulating gastric emptying. So a lot of good effects here we're going to see in terms of helping to reduce actual food intake, and we're also going to see better effects in terms of like insulin levels and glucagon suppression there. So what we're going to see with patients with type 2 diabetes is that they're going to have diminished levels of insulin because they're kind of wearing out their beta cells. We're also going to see that they have lower levels of postprandial, or after they're eating, GLP-1 levels as well. So we're going to see they have suppressed GLP-1, suppressed insulin levels, and they're also going to have elevated glucagon levels. So it's kind of like they can't respond that well to glucose because they're just worn out the system. So normally, if a healthy patient without diabetes is intaking food, they'll suppress glucagon. They'll have elevated levels of GLP-1 and insulin. But for these patients, that has gone awry. Other things we're going to see with the GLP-1 or with GLP-1 itself is that we're going to see less glucagon. We're going to see slower gastric emptying, and we're going to see increased satiety. So again, they're going to be feeling more full quicker. So we're going to see there's a couple things we can do. We can either try to supply exogenous forms of GLP-1, or we can try to prevent the breakdown of the GLP-1 that the patient might be producing anyway. So a couple ways we can do this. So first off, we're going to have our incretin mimetics. These are drugs that are mimicking the effects of GLP-1. They may be wondering why I have a picture of a Gila monster here on the slide. And this is because actually the first one of these drugs here, exenatide, it was, interestingly enough, the Gila monster, their spit, their saliva, is very homologous with our own natural GLP-1. Who would have figured? And so once we discover that, and again, I don't know who the scientist was that took the spit of a Gila monster, sounds very specific, but they were able to find that it looks a lot like GLP-1 in terms of the amino acid sequence. And we're able to give this, right? And don't worry, we're able to make this synthetically. It's not like we're, getting a whole bunch of, having a bunch of Gila monsters spitting into a vial or something. But basically, we can give this along with things like metformin or sulfonylureas and help to do things like increase satiety. So that way they're not intaking as much glucose. We can increase their insulin secretion. We can decrease their glucagon secretion, things like that. Also, an additional benefit is it does cause some weight loss, right? So we're going to see that, again, because you're intaking less calories because, you just don't feel hungry, that weight loss is pretty common with these. Now, exenatide or Byetta was not too useful at first because you're going to see it has to be given pretty frequently. So twice daily sub-Q injections. And this might be in addition to the insulin the patients are taking anyway. So you're adding on additional sub-Q injections because, again, so it's a protein, so it has to be injected there. Other things we'd see here as well is you're going to see some nausea and vomiting associated with this. This is mostly due to decreased gastric emptying because there's going to have more stuff sitting there on the stomach, so they may feel that need to vomit is associated with that, but that typically goes down with time. It's pretty rare that these cause hypoglycemia on their own, but if it's combined with something like sulfonylurea, then that's a little bit more likely. Certainly, you're going to see weight loss, which could be good for your patients, but also could be bad depending on what their weight currently is. And can cause pancreatitis as well. So kind of a unique sort of side effect you're going to see there. Now, since then, we've had other ones that have been developed that are able to have kind of more favorable pharmacokinetic profiles. So, for instance, we have things like liraglutide, dulaglutide, and albiglutide. There's actually a newer one I just read about recently called semaglutide. But again, I'm only going to test you on the ones that are listed here. Some of these are nice because they can be administered like once weekly as a sub-Q injection. So it's kind of a big benefit there. Again, they're proteins, so they're going to be pretty expensive, but again, they may have issues in terms of like getting insurance coverage for something like this. And we are starting to see more off-label use for this as weight loss alone. And just personally speaking, I can tell you, I had an uncle who was a type 2 diabetic patient who was pretty overweight for most of his adult life. I remember going in and seeing him one year at and I just from like I remember seeing him one year at 4th of July, and I saw him at Thanksgiving, so less than a year. And the guy looked like a shadow of himself. He had lost so much weight, and I was like, wow, like what in the heck did you do? It looked like he had gastric bypass surgery or something. He's like, no, my doctor put me on liraglutide for my or Victoza for my diabetes. And I was like, holy cow. And actually, got to the point where he'd lost so much weight, he just didn't want to eat at all because of that satiety effect. That he ended up actually getting put into the hospital because he'd had malnutrition. So again, it can go too far in one direction there. For sure. And I think I just saw recently that that one drug, semaglutide, in patients, I don't remember what the time frame was, but it caused like a 14% reduction in body weight, which is like huge for a lot of those patients there who are overweight. So again, you might be seeing more and more use for this off-label, but again, getting insurance coverage from that standpoint would be pretty tough, I would imagine. Anyway, next up, we have our DPP4 inhibitors, or dipeptidyl peptidase 4 inhibitors. This is an enzyme that's normally responsible for metabolizing GLP-1. If you're able to inhibit that enzyme, then whatever GLP-1 that patients producing themselves is going to be lasting for longer, so it should be more effective there. We have a couple of drugs in this category, including allogliptin, sitagliptin, saxagliptin, and then linagliptin. Note here that these are oral, so that's kind of one benefit they have over the incretin mimetics, like liraglutide, but they're going to be less effective overall. So you may see it used occasionally, but I see this less and less often now that the incretin mimetics have kind of taken hold a little bit more so. Here, in terms of side effects, you can see some patients having allergic reactions, including angioedema, and then rarely you might see Stevens-Johnson syndrome there. So kind of comparing the two categories together, your GLP-1 agonists like exenatide or liraglutide versus DPP-4 inhibitors, again, both are going to help with insulin secretion. They're going to reduce glucagon. You're going to see relatively low hypoglycemia associated with this. Both of these, you're going to see very little hypoglycemia associated with both of them, so they're kind of safe from that standpoint. You're going to see reduced postprandial hyperglycemia. In terms of gastric emptying, satiety, nausea, vomiting, and appetite suppression and weight loss, this is all going to be with the GLP-1 agonist, and not really any of this is seen with the DPP-4 inhibitors. So it's kind of a downside from that standpoint, from a satiety and a weight loss standpoint. In terms of administration, again, your GLP-1 agonists are injectable versus oral for the DPP-4 inhibitors. And then you may see things like pancreatitis and for the GLP-1 agonists versus Stevens-Johnson's, kind of as their unique side effects you may see there very rarely. So it's kind of a good table to kind of compare that and contrast the two categories there, because again, they're working on kind of two sides of it, either providing more GLP-1 like activity or reducing the breakdown of GLP-1 the patient is producing. The last class we have here is going to be our sodium glucose co-transporter inhibitors, or SGLT2 inhibitors. We have a couple of drugs in this category, including canagliflozin, dapagliflozin, and empagliflozin. Again, I don't choose the drug names here, but I think these are kind of silly. Normally, what you're going to see in the kidneys is that you will have glucose being filtered in the glomerulus, and then they get reabsorbed in the proximal convoluted tubules, right? Well, what you're going to see here is that by inhibiting that reabsorption, you're just going to pee out all of that glucose, right? So because you're urinating all that glucose, you're going to see lowered blood glucose because you're not reabsorbing it. And you can also see reduced body weight. So this is another one that can cause some weight reduction. However, there's going to be some side effects. And again, this is the newest class. We're still learning things about it. But because you're peeing out all of that glucose, there's going to be a lot more glucose in the urinary tract. You can see things like urinary fungal infections. Right, so that's kind of a unique side effect. You can see things like hypotension because all that glucose is going to be drawing water out with it. You can see things like kidney dysfunction as a result of that. You can see issues in terms of causing more bone resorption or causing fracture risk, because you can end up seeing some calcium reductions due to the drugs here. Canagliflozin specifically has caused this. And then there's actually a risk for causing a euglycemic diabetic ketoacidosis. Again, a lot of this has to do with the fact that you're urinating out all this glucose, and thus you can cause a DKA sort of effect there, which is pretty rare, but can occur. So again, if you had someone who developed like a urinary, like a fungal urinary tract infection, which is pretty rare, this is probably a drug class that's probably going to be most likely to cause it there. So anyway, so this is a good table here to sort of walk through and show you the different effects from these various medications here. Kind of picking out what you want to do in terms. Oops, sorry. Random popping up here. So in terms of which medications to pick, this will also tell you the risk for hypoglycemia, the effects on weight, the sort of like notable side effects, and then the cost. And so being able to sort of parse this out, because again, I can ask all kinds of test questions off this. We usually start out with metformin because it has a pretty favorable side effect profile, and it also has good effects on A1C, dropping the glucose levels. It's low cost. Again, most people are going to start with this by itself, okay, with metformin. Also, it's going to cause a little bit of weight loss. if anything, which is nice. But the GI side effects are pretty rough. Just know who's not going to be a good candidate for metformin. Typically, renal dysfunction is a big one you're going to avoid there. So if they're on this and they don't have good effects by themselves, then you can add on something else. You notice here, there's not one gold standard second drug to add on here. It's really going to be dependent on what the patient can afford. It's going to be dependent on what the patient is kind of amenable to. Are they overweight? And maybe something like a GLP-1 agonist might be a good option there. Is it to where you're really worried about hypoglycemia? Then you might want to shy away from some of these medications. So again, being able to go through and say, okay, what's the next thing I want to add on? Look for things like, for instance, if they had CHF, I probably wouldn't want to use a TZD like pioglitazone or rosiglitazone. If they had a history of recurrent urinary tract infections, I probably wouldn't want to use an SGLT2 inhibitor, right? So those are kind of things you want to kind of hone in on, contraindications or reasons why it might be really good for a patient. And then you may consider something like add-on triple therapy. And this is where you're probably going to be more likely to start to think about insulin being added onto the regimens here. For most type 2 diabetic patients, you're probably going to start with a long-acting insulin. So something like an insulin degludec or Detamir, Glargine, something like that, typically once daily. And then that can be in addition to like metformin and whatever else you're going to put them on. So then you consider triple therapy, and if they still are not able to be controlled even after all of that, even after you've assured compliance, which would be pretty hard to do, then you can put them on like a basal bolus sort of regimen there like you would a type 1 diabetic patient. Hopefully you don't get to that point. Hopefully they'll get under control with some of the other ones here, but that's kind of the general trend of things as we'll see. So again, be able to kind of pick out like what's a good drug depending on the patient, what are the contraindications, things like that. Good to know. Anyway, so that's it for this section. Do you guys have any questions I can answer before I let you go for the day? So you have your prescription assignment due on Friday. You'll also we'll have one more week of classes. There's a quiz this week for the diabetic medications there, so you can kind of go through that. We'll have one more class next week, and then we'll have our final exam. So it's going to be over before you know it, and you're going to be out on rotations pretty soon here, which is pretty wild. That's awesome. Yeah, thank you. I don't see any questions on the sticky board, but... Yes, Alyssa, what's your quick question? That was more of a declarative statement than a question, but... Are all these meds considered lifelong treatment? So for like a type 1 diabetic patient, probably, because again, they're going to require insulin the rest of their lives and they cannot produce their own. So yeah, probably. For type 2 diabetic patients, though, it's going to be or possible with the weight loss. Yeah. So some of it can be reversible, right? So you can consider something like insulin sensitivity has some degree of reversibility. Now, if they've had actual degradation of pancreatic function, that may be more difficult to get back, right? So especially for like really long-standing, more severe diabetes. But if you have someone who is able to like lose weight, get their diet under control, you can reverse a lot of this. And so you may have patients who are on metformin or on an insulin regimen. They may not need to be on that lifelong. They can eventually get to a point where they can stop taking some of those if they get their stuff under control. However, lifestyle modifications are really tough to do. It's really tough to break people out of these, habits. So whatever you can do to try to help reinforce that. And again, while people being on medications is job security for me, I prefer fewer drugs for patients. So if you can really encourage that, help out with education, getting your diabetes educators on board, they are super helpful and they're really good at what they do. Get them on board and they can kind of help out with some of that as well. So yeah, not necessarily lifelong, but yeah, it's a very good question. Thank you. Any other questions? All right, well, I don't see anything else, so I'm going to cut off for today. Sorry about the camera issues. I'm going to try to get those fixed for next week. I apologize. Otherwise, I will see you all next time. If you have any questions, feel free to email me. As I will see you later. Have a great day.